Hepatitis B. Etiology, pathophysiology, and pathology. Hepatitis B virus, HBV, is a double-stranded DNA virus. The E antigen is a protein subunit of the core of the virus that is excreted by hepatocytes. Excess surface antigen is also found free in serum. The histological picture is of an acute hepatitis with liver damage due to immune clearance of the virus. Epidemiology. Horizontal transmission is via parenteral transmission and sexual contact, and probably by close contact in young children. Vertical transmission accounts for the high rates of infection worldwide. The prevalence is falling, although worldwide there are still 350 million chronic carriers. Clinical presentation. Common. Most infected individuals are asymptomatic. Some will have fever, malaise, nausea, and right upper quadrant pain. Up to 4 months after exposure there may be self-limiting jaundice, which rarely lasts more than 1 month, Fig 60. Rare. A cholestatic phase and relapses are uncommon, unlike hepatitis A. The presence of immune complexes containing hepatitis B antigens leads to extrahepatic manifestations, e.g. polyarteritis, glomerulonephritis, and myocarditis. Physical signs. The acute phase may produce signs of an acute hepatitis. Signs of chronic liver disease develop later in some cases. Investigation. Liver biochemistry. High serum transaminases and an elevated bilirubin may be seen in the acute phase. Evidence of infection. Serological markers of HBV infection are shown in Table 45. During the acute phase of illness, HBV DNA can be detected in the blood. This is cleared by 2 months in greater than 90% of cases. NB. Hepatitis B core IgM is often the only marker of infection in acute liver failure, as the virus will have been eradicated by the immune system by the time liver failure occurs. Treatment. No treatment is indicated for most patients with acute infection. Lamivudine is now being used in those with acute liver failure, and liver transplantation may be needed. In those with chronic active hepatitis, with evidence of ongoing inflammation biochemically and on liver biopsy, treatment with interferon alpha or lamivudine may be suggested after review by a specialist. Adavofor or entecavir may be used in the event of lamivudine resistance. Liver transplantation is offered for patients with decompensated hepatitis B cirrhosis. Complications. Chronicity. Persistence of HBsAg in serum for longer than 6 months suggests chronicity. Overall, 10% of adults and 90% of neonates or those who become infected in infancy will become chronic carriers. The carrier rate in the UK is 0.1% compared with 10 to 15% in Africa. Chronicity is less common if the acute attack is more severe, i.e. associated with jaundice. Acute liver failure. Due to enhanced immune response with rapid clearance of the virus. Others. Polyarteritis and glomerulonephritis are rare. Prognosis. Good unless acute liver failure ensues. Prevention. Vaccination along with strategies to prevent exposure. Children and adults. Recombinant vaccine is given intramuscularly. After 3 injections 94% will become immune. Low responders, often the elderly, immunosuppressed or those on renal replacement therapy, may need a further booster and course of vaccination. For all receiving vaccination, a booster is recommended every 5 to 7 years to maintain HBsAg levels above 100 IU/L. There is an argument for universal vaccination in childhood to eradicate HBV worldwide, but currently it is recommended for selected groups only. Table 46. NB. Remember to tell a patient with HBsAg to avoid unprotected sexual intercourse unless his or her partner is immune to hepatitis B. Neonates. If the mother has HBV, give hepatitis B immunoglobulin at birth as passive immunization, together with hepatitis B vaccination.